There are things in life that we dread. For me, it's going to the dentist office and having them say, well, we have a 2-hour procedure we need to do, and unfortunately, we're out of lidocaine. Another one is to say, oh, look at that. I get to follow Dr. Mervyn Singer on the schedule. And there's also no lidocaine for you. Okay, we're going to change gears. We're going to talk about things using different parts of our brain now, more specifically about competencies and where we are with critical care. Some of this is U.S.-centric, but I think a lot of the broad topics that are embedded in this apply to each of us. And let's walk through this together. Okay, this is where we live in the ICU. This is what rounds look like every day, with everyone moving away for fear of the questions that may be asked, and then you may not be deemed competent. So what I'd like for us to do, we have about a half an hour. I'll try to finish a little ahead of that schedule. But let's talk about the importance of this, and more importantly still, what exactly is competency? If you look through the literature, and we're going to review a little bit of this, there's not really anything there. It's something that we do by feel, broadly. And if this is important and we can define it, then what are the variables and the competencies that are most relevant? And this is not just about doctors, too. We're seeing an increasing proportion of other than intensivist physicians as well as non-physicians who have an active day-to-day role in the care of very sick and complex patients in the ICU. And then where can we start? I'll offer a little bit there. So let's start first with a little case scenario. And I bet every one of us has seen this patient before. A 40-year-old woman admitted to an intermediate care unit. So we're going to make an ICU that's not in the ICU because we're going to talk about territory and turf. And she's there for 12 hours for close observation. She is confused, disoriented, febrile, and stiff. So they're walking down the pathway of meningitis for this patient with antibiotics. The nurses talk to each other, and through the grapevine, you're called to come and look at this patient and find that she is in fact stiff. You get a blood gas on her. You look at the calculated bicarb, it's less than 10. Her pH is less than 7, and her PCO2 is greater than 100. And everyone looks at each other and says, how did that happen? How do we let these kind of patients get to places where people that don't understand what is going on are looking at the patient? And then it comes to rescue. This is why we have things like rapid response teams. But unfortunately, once someone dives off the cliff or the building is engulfed in flames, this is no longer rescue. And this is what we try to do every day with our patients. The same is true for competency. So if we start to define competency and look at the elements of that, our focus has largely been on procedural and cognitive type things. But there are behavioral aspects of this, there are communications, there are other things that are here. So how should we define this if we look at each of these different domains about competency? And what tools are actually available for us to identify competencies and measure them? Well, in the United States and in some other places, the Accreditation Council for Graduate Medical Education, as we know, has defined competencies for trainees and put them in each of 6 domains: patient care, medical knowledge, practice-based learning, communications, professionalisms, and system-based practices. And program directors for trainees in the United States have all devised their little sheets, and they check off the boxes for each of these things. Some of these domains, we actually have variables that we measure that are at least semi-quantitative. But for a lot of this, we do this. And it's a very subjective process. Yep, they've got that figured out. I've watched him do a couple of central lines, and he was fast and seemed confident and remembered to do the drapes and seemed okay with the ultrasound. Is that really competency? Okay, so that's for the ACGME. In Europe, a number of years ago, Julian Bion and colleagues started a program, gosh, it's been a long time ago now, called Competencies. And this is a highly detailed document. It's a telephone book of information that's there, and it goes through in painstaking detail, point by point, sub-point, sub-sub-point, all of the different competencies that are there. The stated goals for this you can see here: to assure a high-quality level education in intensive care medicine, and to harmonize training. So you see, this is also an education document, just like what the ACGME does. Well, that's fine, but if we're trying to measure these things in our trainees, is that directly applicable to people that are post-training and how we assess their competencies? More about COBITRICE. So here are some of the categories that are there: resuscitation, diagnosis, disease management. So this is a nice organizational structure. Rather than looking at this like a typical textbook would, organ system by organ system, this coalesces all of these things together into groups that is more aligned with how we take care of patients. Well, that's better. Certainly that's better for how we look at competencies in our patients, in our trainees, excuse me, and how they care for their patients. But here's the problem, and this doesn't come from the COBITRICE document, but I found this branching diagram. For all we know, this could be the branching arms of treatment for sepsis, right? For where we're going with everything. But the point being, this is too complicated. And once we try to apply this day to day from a pragmatic and practical standpoint, this doesn't work quite so well. Here's an example right off one of the web pages from the COBITRICE that's there. And by the way, if you're interested in this, it's very simple to set up an account for this, and you can look at these either on the web page, or they have both a short and a long version of the PDF that you can download to that. This is a companion to the PACT document that they have that also aligns the knowledge domains along with this. But let me emphasize one last time before we move on. This is about training and education systems as opposed to definition and measurement tools. And what I want to talk to you about today is the bottom line there: definition and measurement tools. How do we do that? Well, competency is like everything else that we do in the ICU. Some of it's physiology and pathophysiology, so there's a lot of P's that are there, but the big one in red is the one that we deal with. Because as soon as we start to deal with competencies, people immediately start to worry about the territory. Wait a minute, are we talking about a closed ICU here? Are you telling me that you're going to assess what my abilities are and whether I can come into this ICU? Well, let's go talk to the chief of staff about this, and then it snowballs from there. And we get into the politics of the issue. And this has actually been a significant rate-limiting variable in our efforts to try to develop further aspects of competency. Let's take a look at a couple of papers. This was published in the Blue Journal in 2009. And the people that you see here, they did a really nice job. A bunch of really smart people got together, and they communicated electronically. They were in the same room for a few days, and they tried to say, okay, well, what are the competencies that are there? And what they developed, more or less, was a distilled or executive summary version of the COBITRICE that was there. But it was highly focused on pulmonary critical care. Here are some examples of what was within that document that you can see. And as you just look down the list that are there, you see things about diseases of the upper airway, pulmonary malignancy, pulmonary infections, and so forth. And it gives a task force score. This was a subjective score of what they thought was important. Well, okay, well, this was a good step in the right direction, but it falls far short of where we need to go in assessing competencies for practitioners. And again, you can see here, there's the part that was more specific to critical care medicine. And there are a lot of things that are here, but there's still more that needs to go. One example would be from 2009 to the present, over the last 8 years, the role and prominence of bedside point-of-care ultrasound in how we care for patients has dramatically escalated in what we're doing, and this isn't reflected in this document any longer. So then we started to see some editorials that talked about this, and it talks about the workforce crisis. And here there's a pro and a con, and I'm showing you the con, why the United States, and that's C-O-N, not K-A-H-N, as you see here, why the United States does not need more intensivist physicians. And what this commented on, let's go right here to where the red is, rather than continuing an unwarranted push to increase the intensivist supply, we suggest alternative workforce policies that emphasize novel interprofessional care models to improve ICU quality in the absence of intensivists, combined with the limitations on the future growth of ICU beds. So what is that really saying? It questions whether or not you have to be a fellowship-trained intensivist in order to care for ICU sick patients. So let's delve into that a little bit more. So let's look at a timeline here, and along that timeline is a patient with worsening illness, and let's see what we've got. So we start over at the lower end, a low-risk monitoring patient that's admitted to the ICU, and somewhere around about here, that patient requires a central line placement. In the old days, that was considered a threshold where we started to say, okay, this patient needs to be in an ICU, and yep, they need to have an intensivist. But things have changed. Now they require active resuscitation, and we'll keep moving up the line, and things have changed with this. So now, in my ICU, for example, the patients who present with septic shock, who do not respond to fluids, who require pressors, about 1/5 of those patients have a traditionally placed central line. The remainder of them have a peripherally inserted central line, a PICC, that is placed for their resuscitation, and it's a short-term resuscitation device, and that works well. But it also changes the dynamics of where these patients are and how they're cared for. Now requiring active resuscitation, well, with bedside ultrasound, a little bit less guessing, requires active titration of multiple therapies. Well, surely that means an intensivist. Well, maybe not. In a community hospital where there's tele-ICU or some other equivalent technology, perhaps a hospitalist can do that. So now we've moved the bar for where an intensivist becomes involved down to here. Okay, well now this patient requires intubation and titration of the mechanical ventilatory stuff or actively trying to die. And so we're living closer and closer to this end of the line. So as we've moved with other technologies and expectations, other people are entering into the picture to care for some pretty sick patients. And I don't know what your ICUs are like. Actually, I bet I do. If you were to go to your intermediate care units and measure your acuity of illness, I suspect 1/3 to maybe half of the patients that you currently put in an intermediate care bed even 5 years ago would have been in your ICU. There's an overall increasing acuity of patients that we see within the hospital, and it's influencing this dynamic here. Okay, so here was the yes for how we do this about non-physician providers in the ICU. And I want to read you a couple of things here. I'm just trying to see how good my eyes are. Maybe I'll cover this one. Okay, board-certified intensivists have spent at least 4 years after medical school training, and they have passed an examination. So they're better, right? Okay, how about, well, PAs and NPs save many lives and help immeasurably. The best among them are the first to agree that they are not experienced in curricular exposure of board-certified physicians, right? Well, I'll challenge that one. In my ICU, we have 6 NPs and PAs, and 4 out of the 6 of them, I bet you could sit them down tomorrow in the United States in front of the American Board of Internal Medicine examination for critical care, and they would pass it. You should see them put in central lines. You should see them do intubations. Now, that's heresy kind of talk, but it makes us rethink exactly what is the timeline and how do we train people and what exactly are the skill sets. So I'm not going to read you any more of this, but let me give you what I think the bottom line is of this article. Protect and grow the status quo. And along these same lines, you've seen several papers that have been published the last few years, largely in medical ICUs in the United States, academic medical centers that say, hey, we don't have anybody in the hospital at night, and our patients, they do just fine. In fact, when we compare mortality of those that have in-house intensivists versus those that don't, we don't see a difference. Okay, Well, that's fine for your COPD exacerbation who's intubated for 36 or 48 hours, it's in the ICU. But this doesn't work in my ICU, where we have fresh VAD patients and terrible right-sided heart failure and transplant patients that are unstable, and on and on and on with what we're doing with those. And so we're measuring different things. And so this is the P politics, the red one that I showed you that you see in play here. Okay, I'm going to go back. So here's my bottom line with this and how we look at the competencies with it. We've built a system largely that's dependent on people being based in an office and coming over to the hospital. And when patients get really, really sick, you can't take care of them with a telephone. Somebody has to be there to actually do these things. And the ones that are there, back to the competencies. All right, I'm going to show you a couple of slides here from the Society of Hospital Medicine, and these are from 2014, so it's coming up on 3 years old. These guys in the United States have now started to talk not to the American Board of Internal Medicine or Surgery or Anesthesia that have board examinations for critical care, but the American Board of Family Medicine, and they're trying to go to the American Board of Medical Specialties to define a board certification pathway for hospitalists for critical care outside the current system that exists. So here's what they've been trying to do. This was a task force they had a couple of years ago, and they did a survey. We did a similar one with the Society of Critical Care Medicine, and just as a punchline for that, what we found was that if you moved away from an academic medical center, about 2/3 of the critical care provided in the United States is provided by hospitalists, not intensivists. And they work on a consultative basis when ventilators and other things are involved, but the day-to-day management of these patients is performed by hospitalists. The opposite is true. About 80% of these, or 3/4 of these, are cared for by intensivists in an academic medical center. But the academic medical centers are the ones making the rules, but they're not aligned with a lot of what's going out in the community. Okay, so what they found, not surprisingly in their survey, is about 70% of hospitalists care for ICU-level patients, and you can see the numbers there with community versus academic, participate in rapid response teams and code blue teams. And so you can see these guys are taking care of a lot of sick people with what they're doing. Why does this happen? Well, if I'm a hospital administrator and I'm managing that hospital and I have a fixed budget to try to provide the care for the ICU and I want to go hire intensivists and I'm looking at my bottom line on the spreadsheet, if I buy hospitalists or I buy an intensivist, for the price of one intensivist, buy 2, get 1 free with the hospitalists. So it's more cost effective to do this. And if we've got telemedicine and these other things, hey, what could go wrong? So this is what's happening while we debate the politics of all of this. What's actually happening ad hoc in the background is that all of these competencies are being defined by hospital administrators and others as they are tasked day to day to come up with a solution to these problems. Now, what was important here is when they said, hey, well, how do you guys feel about taking care of these ICU patients? About 1/3 said, this is pretty deep water that I've waded into. I need some help with this. So what they've done is to train competent hospitalists to do this. This is the notable goal that they're trying to accomplish with this program. And so they've defined a curriculum. They've used things like the fundamental critical care support of the FCCS from the SCCM and other groups to try to do this. And this is what you see on this page is the substitute for a fellowship. Okay, well, I don't agree with this, but I'd also challenge however many years in our current system that what we're doing, and what's in the middle and how do we measure those competencies. Here are the didactics that they look at, and it's very targeted and directed and is the breadth and scope of what we do in critical care. This is not going to teach anybody how to take care of a patient who's had a VAD inserted, or somebody who's had a liver transplant who had terrible reperfusion injury from their DCD donor liver, et cetera, et cetera. Okay, self-directed learning, you can see the things that are there. These are okay, but that's really all they are is okay. Any of these kinds of classes where you're sitting in lectures all day long, the durable exchange of knowledge is about like this. In fact, even as I stand here with you today, PowerPoint is a barrier to learning. This is not a good way for us to be learning and teaching. Simulation is part of their curriculum as well. Now, I wanted to call your attention to this, and the arrow keeps moving depending on the thing. The red arrow is supposed to point at the 5. So preparation for unsupervised practice. Let's read that second bullet together. Prior to performing a procedure unsupervised, trainees, these are the hospitalists, must have at least 5 satisfactory evaluations completed by his or her attendings or consultants. I'm not so good with 5. That's really not a very big number. And there's a lot of things that can happen that you won't see even if 5 procedures go well. So they've tiered these things for an open ICU, a closed ICU, and something that's in the middle for this. And I think this is okay. Just as a side and a commentary, my opinion on this, I think open and closed as terminology for ICU are anachronistic terms. We need to abandon those. All those words do is get people's hackles up and stimulate a political and a turf discussion with this. What we really need to be looking at is how we work alongside of people, co-manage, and we're not trying to take anybody's patients away from them. That's not what we do. Okay, so the tiered ICU and what the role and function of is a hospitalist. So what you see, let's drop down to the bottom bullet, also in red here. At the end of the year-long training program, a certificate of adequate completion of all aspects of training, a procedure log, and a reference letter from the faculty will be provided. Well, I'm now the hospital administrator again, looking at this buy 2, get 1 free, and you have this piece of paper. But this really doesn't directly address any of the competency issues that are there. Now, let's look at another right to left arrow specifically for competency. So if we start here, non-physicians, advanced practice care providers that are here, non-intensivist physician care providers, non-intensivist physician ICU consulting, primary, all the way over here to fellowship trained. So what needs to happen, this arrays the differing levels of care that are there, but the competencies that are defined for a given hospital, it's not one size fits all for this either, just like sepsis therapy. So it would vary depending on looking at your specific hospital, what you're doing, and how things function within your building and ICU. Okay, well, what about me? I've been doing this now for 30 years. Am I competent? I know I sure feel a lot more fatigued after the night shifts that are there. The last however many years, 20-something, I've spent a lot of time supervising fellows and residents with doing procedures. But what happens when somebody says, here, you take the big needle now, it's your turn to poke a hole and do this? I'm not doing as many as I did, and it's an effort to maintain your procedural competency to do those things. And I bet you, going into an academic medical center, if you walk into someone who's a physician scientist and said, here's the laryngoscope, go for it, you'd see some sweating from a lot of people that are out there. Nobody wants to talk about that, but that's the unspoken reality of all of this. Now, this came from a few years ago from Australia and looks specifically at the process of aging. So this is a hot topic in the United States now as well, too. And there's a lot of revolt against this, where, okay, you're this age, pick a threshold, you're still practicing, and what is your cognitive skill set? Maybe we should do cognitive testing and try to quantify cognitive impairment and see where people are with this. And does that wisdom experience really count for so much? And how do we define competencies with these things? So I don't have any answers for this, but understand and know that these things are being talked about. Okay, another one that's here, and this is all the rage right now, that's the same picture I showed you earlier, and that's physician burnout. And this is a threat to quality and what we do in the ICU every day. And I suspect many of us have problems with burnout. We work very hard with what we do, and this affects where we are, and we have to deal with this. So there are groups in the United States around critical care right now that are looking at this, and there's an Occupation and Safety Health Administration that looks at noise standards and particles of dust in the air and all of those kinds of things that are there and what your exposure to those things are. But what about the risk factors for burnout and our exposure to these? So there's a discussion now that perhaps we should be looking at measuring these as well too. So let me close with just a few slides that talk about the process And rather than say, here's the solution for the world, let's just talk about your hospital. Okay, so where do we begin with all of this? So I've just made a few here. First, start by characterizing your ICU functionality. For your specific unit, what kinds of things that you do there, and as a consequence, what care model does that drive? And remember what I told you about, don't do the open-close thing with this, but rather look at how you collaborate with your colleagues who admit their patients to the ICU. Talk about your strengths and weaknesses. We do that for lots of things. Prioritize ICU competencies and then formulate an action plan. Now, what this really says in prioritizing is don't try to fix everything. All you're going to do is flare up all the politics and get into problems with that. So pick one thing or two things and work with that, and we'll talk about that. So let's look first at the step one of characterizing your ICU functionality. Who are the patients that inhabit your ICU? And you don't need to have a complete comprehensive list, but just pick the top 2 or 3 that are there. Neurosciences, liver transplant, whatever it may be that you do. And what are their most common ICU-specific care needs? Is it around their resuscitation? Is it use of blood products, use of pressors, et cetera, whatever it may be that's specific to that. Mechanical ventilation, dialysis, you see all of the things that are right here that are possibilities. And then who provides these needs? And what's very important is this last one in red, at 1400 and at 0200. This is what I call the mom test. It's 2 o'clock in the morning, and your mother is admitted to the ICU. So what are your expectations? Are you okay, if you're in a teaching hospital, for example, that the person taking care of your mom graduated from medical school last year and is there unsupervised with somebody else on the telephone to help them? Is that okay? And if it's not okay for your mom, then why is that okay for somebody else's mom? So this is very important in the philosophy of how you set these things up. So do all of this and then pick just one thing and start there. Okay, the next step with this is look at your care model. And as I've said, don't use the words open and closed. Talk about consultation. You see a patient, and this might be someone, for example, who's had a stroke, who was received TPA in an emergency department and is now admitted to your ICU, does not have significant comorbidities. And so you consult, assess the patient, and follow from a distance. Co-manage would be that patient with the VAD that we mentioned that's there. And the primary service is someone shows up in the emergency department with severe sepsis and is admitted for pressors and fluid therapy, et cetera, with that, and doesn't otherwise have a doctor. So you're the person that takes care of them. And then look at how that happens and who writes the orders, who does the procedures, who makes rounds, importantly, who the nurses call when they have questions and problems with this. And then acknowledge the political barriers that are there. Now, I'm going to say this 3 times in the last minute and a half, but you can see here, do not use the definition and implementation of ICU competencies to address political turmoil. If you do this, you're going to fail. Step 3, enumerate strengths and weaknesses for your clinical care. What are you doing right? Where can you do things better? What about infection control? How are you doing with the procedures with that? What are your line infections? All of those kinds of things that are there. And then look candidly at your relationships with the services who admit patients to the ICU. And then once again, the politics of this, I am not going to get this right. I keep pushing the wrong one. Do not use this politically to define the ICU competencies. Okay, step 4. Now you start to prioritize and look at your competencies. Look at the cognitive procedural communications. You don't need to reinvent COBITRICE or other similar documents. They already exist, but you also do not need the level of detail that we discussed. So pick one category and one element and get a quick win and work on that area alone. And at Mayo Clinic, what we did, we looked at how we put in central lines. And this is crazy, but we did this across all the ICUs. It took almost 2 years to do this, about how we do the gowning and draping, how the procedure is accomplished, 2 methods of confirmation that you're actually in the right vessel, by looking at the wire with ultrasound, by doing a capillary test with the IV tubing, et cetera. You have 3 options, but you have to do 2 of them for every single patient, or the nurse will stop you for that. And we did that. Step 5, formulate your action plan. get the stakeholders that are involved, and this is not just an ICU-only activity. So you have to get the heart surgeon or anesthesia or whoever else needs to be involved with this. And don't start with something that's polarizing, that's so-called radioactive. Pick something easy, like the central line, and how you do that. I say easy, it's less difficult. Okay, this is bad. Last time I'm going to mention the politics with this. Don't arm wrestle and use this to define turf. So let me summarize again. We've reviewed why this is important. We've talked about competencies, etc., all of these things, but all we've done is just taken a small, quick look through the keyhole that's here. There's a lot to be done, and this is happening. Whether it's happening in your hospital specifically, ad hoc, it's evolving, and lots of people are getting involved with critical care who don't have similar backgrounds. Don't build barriers to that. Get out in front of it and lead the process. Don't try to stop it. And I think that's it. Nope. Okay, same old thinking gets the same old results. Thank you very much.
Thanks, Professor Farmer. We have some time for questions. I actually got a question I want to ask. Defining competency can be tough, but it can be measured as long as you know what you're looking for. And such as central lines, ultrasound, intubation. But the challenge is, how do you define what is an expert and how do you measure it? Someone once told me that an expert is a person that knows where the boundaries are and where he knows where he can flex his muscles and where he won't fall off the cliff.
Yeah.
Yeah. So do you think it's important, once we can get our competencies up, and what is a competent intensivist, but do you think it's important to measure what makes an expert intensivist?
Yeah, so what you're really getting at are two things. One, the first is, do we define the floor or do we define the ceiling? And the floor would be the minimum level of competency that's required to do a procedure or whatever the particular competency. And the ceiling would be for an expert. And an expert may be somebody that knows as much as me. That's what we like to think, I believe. But that's probably not really true with where things are. I think it takes a dispassionate look. Perhaps this reflects a pessimistic view of it. Maybe it's more pragmatic. But personally, I don't think I would start with defining the expert, the ceiling. I'd start at the floor, because more people are closer to that. And it's a little easier to get agreement politically on what the minimum standards are for something than the maximum standards, because the maximum standards can feel exclusionary to people in what they do. And I'll use again, I thought it was really good what was happening at Mayo when we did the central line thing. And it took a lot of coordination, because this applied to the ICU, it applied to the anesthesia and the OR areas, etc. But we don't do this without ultrasound anymore. I mean, it's a very scripted, highly choreographed competency in how everybody does it. And it's stuck. It's done very well.
Yeah, good answer. Great. Good. Jason Paul, our SICM president, has a very nice question that you want to ask. And he's asking actually, why hospitalists in the ICU? Why do they spend less time training? Why are they less costly? Why are hospitalists and not intensivists? And he's asking, are we at risk of training and deploying people the same way, simply calling them a different name?
Yeah, Jason, these are really good questions too. So the first thing about why are they less expensive, it's just simple salary structure. A pediatrician is not paid the same thing that a heart surgeon or a neurosurgeon is paid. And along that spectrum of salaries, a hospitalist is paid less than an intensivist is paid. Anesthesia salaries are more closely aligned, because a lot of intensivists are anesthesiologists, with what that pay scale is. And then there's a supply and demand thing as well too. So a lot of people try to solve their budget problems by using people that don't have the training like the hospitalists to do that. I will tell you though that I've seen some pretty amazing things with the hospital. There's one hospital, and I won't state the location in the United States, but it's a 1,500 bed hospital. They do close to 4,000 cardiovascular pump cases a year, and they have a very large CCU that adjoins that feeds these patients to it. The medical director of that ICU, when I visited, was a cardiologist, and there was one other intensivist that was there, and then they had 6 hospitalists that did nothing but work in the CCU. And as they gained skill sets with this over time, these guys put in pacemakers, they placed balloon pumps, they managed high complexity patients, and they did it just as well as anybody else did. And that was, gosh, almost 10 years ago that I saw that, 2008. But it was the first time that really opened my eyes to what's tradition versus what's reality for what we need for these skills. And we can dig in our heels and say, well, we'll just do this other, but somebody else is going to come up with a different solution, and it's more cost effective, and then we're going to be on the other side of the glass looking at this.
Okay, we have one last question before we break. The question is on, there's a lot of emphasis on trainee competency, but do you feel that there's a need for a trainer competency?
Yes, absolutely. I think there's a need for trainer competency. And it's not just the clinical skill sets as well, too. The days of so-called on-the-job training are going away. So let's look at academic medicine just as an example. In the old days, we'd say, okay, during your fellowship training, I'm going to hang out in somebody's lab for 6 or 8 or 12 months, whatever the number is. And then after I finish, I'm going to identify my mentor, and I'm going to kind of feel my way through this, and sooner or later I can say I'm a physician investigator or a physician scientist and do that. Well, you see a waning percentage of people that approach it that way now. If you want that training, then you want that as a career path, then you go get that training. And so you've got a Master's of Sciences degree, and you have had the background for that. The same way in administration, a physician executive now goes and gets an MBA so that they have the appropriate management skill sets to do that. And an educator goes and gets a master's degree or a master's degree equivalent in adult education or medical education or some other thing. Just because you've been a learner doesn't mean you can be the trainer for these folks. There's a lot that's embedded in this.
Thank you, Professor Farmer. Thanks for the great insight and the great lecture. Thank you, everyone, for the great participation, and we now break off. Thanks.
One last comment, you guys. It was really edifying to have the opportunity to come here and spend time with people. My institution has had a long-standing relationship with the folks here in Singapore with critical care, and it's been really, really terrific. And you guys have got a great thing going here. And just know that the world is proud of everything that you're doing here in critical care. It's outstanding. Thank you.
Thank you very much.